everybody, it's Dr. D, mom of three. I'm so glad that you're joining me today for today's show. Welcome, welcome. Hope you are having a fantastic week, and I hope it's getting warm wherever you are, because yes, we do need some spring, some flowers, to make things a little brighter. Again, I hope everybody's staying safe during this time, and if your state is loosening up the stay at home policies, definitely continue to practice some safe practices. So today I'm excited because we are going to hit on another awareness month, because this is the first show of May. Before I get into that, I just want to remind you that the Dr. Mom Show is a medical informational resource. It does not take the place of your physician or your child's physician. So definitely consult your physician or your child's physician if you need anything specifically to yourself. Also, don't forget to check me out on www.dalenemuchalak.com to see what new projects and exciting things that are going on. You can purchase my international bestseller, The Tripsies and Me, on there. This week is very special because it's Children's Book Week all week long. So you can see the different activities that I'll be doing this week and posting different reminders. As a pediatrician, I always do encourage parents to read at least one book to their child or children every day. So definitely keep posted for that. Also, I'll be doing a live reading this week of my book, The Tripsies and Me, to entice you a little bit to get that amazing lyrical rhyming book with some great illustrations in it. Don't forget to check out Mom, M-O-M, Mom, Meditate, Overcome, Motivate, my devotional. That will be available in an e-book coming soon, hopefully this week, because it is getting ready to be Mother's Day. So definitely, if you haven't gotten a gift for your mom, or you want to get an additional gift for your mother, your wife, your grandmother, and aunts, this would be a great way to do so. And how much more convenient than to have it in an ebook. So definitely stay posted in regards to that. And then, of course, my new book collaboration, Women of War, Peace in the Midst of the Storm. So excited about that. That book launch is in approximately 1 month. Whoop, whoop. Myself and the ladies are very excited about that. So definitely check out everything that's happening. And again, continue to stay safe. Well, this week and today, I'll be talking about arthritis, and this is just arthritis in general. May is Arthritis Awareness Month, so we just want to take the time to learn more about this disease process and get a better understanding. And of course, if yourself or a family member has any of the symptoms, please definitely speak with your provider. So first of all, there's different types of arthritis. I'm mostly going to focus on osteoarthritis and rheumatoid arthritis today. I will have some more shows specifically on other types of arthritis, so check that out too. So those are the two main ones that we probably see most often. To differentiate them, osteoarthritis is what we call wear and tear arthritis. So eventually the majority of people will get osteoarthritis, because since we were little and rolling all around, and from the time we started to walk at approximately a year of age, our bodies and bones have been carrying that weight. And of course, depending on how much you weigh, some people's bones are working harder than other people's. So that's something to keep in mind. So everybody will probably get osteoarthritis in their life. And we'll talk about the joints that get affected. Now, on the other hand, rheumatoid arthritis is an autoimmune disease. So there isn't something necessarily that, for example, pounding, like with osteoarthritis, the weight situation. Of course, the weight doesn't help arthritis in general, but it doesn't necessarily cause or make you more susceptible to the rheumatoid arthritis. Again, it's autoimmune, so of course there's a genetic component, and we've talked about autoimmune diseases in the past. Just last week we talked about sarcoidosis, which is an autoimmune disease. And again, just to reiterate, if you have one autoimmune disease, you are at higher risk of having a second one, or I should say other autoimmune diseases. So again, these are inflammatory processes. Again, I always say in my videos where I talk about anything that ends with itis means inflammation. So let's delve right in now. So we're going to start off with osteoarthritis. So osteoarthritis. So what happens when somebody has osteoarthritis? What signs and symptoms can we see, or how can a patient feel? So normally in osteoarthritis, patients will have pain most of the times on one side of a joint. So it's a unilateral. So they may come in with right knee pain, left hip pain, low back pain, probably one hand bothering them more than another, probably one joint of their fingers bothering them more than the other. Now, one thing to bear in mind is that the joints usually affected with osteoarthritis are the what we call the distal interphalangeal joints. So those are distal. So those are the furthest from us. So we have to remember that. And then, of course, joints that are weight bearing. So weight bearing, again, going back to when we started to walk. So those weight bearing joints are joints that are the knees, the hips, the low back. Those are the joints that are most affected. And again, that goes back to heavier patients are carrying more weights on their bones. So keep that in mind. Now, most of the times, osteoarthritis will start around like 40, 45 is the average age. Needless to say, sometimes some patients will come in sooner with it. Again, weight being one of the most common reasons to bring on these symptoms sooner than later, because that pressure and that pounding that's put on those joints. A lot of times we can see swelling of the joints. If somebody's having knee pain, they can come in and a knee, you can see that the knee's swollen, and then patients can present with something called crepitus. And what crepitus is, we only don't see it in arthritis. We describe crepitus because it's like a noise that we hear, or sometimes you can feel that like crackle, quote unquote. We can see that in other disease processes. But what happens is when you go from a flex knee, so if this is your knee right here and you're sitting down, so your knee is bent. So if you move your knee up and down and you hold your hand, you can do it right now, hold your hand on your knee and you move it up and down. You may not feel anything. Of course, some people's, joints crack, and that's okay. You may hear like a little pop, but you feel this like crackle, almost like you're crushing up paper. So this little crackle we call crepitus. So we call that a poor man's test, because instead of giving imaging, you can get somebody to just extend and flex their knee, and you can feel that, again, that kind of crippling of paper in that joint. And what happens in osteoarthritis is that joint becomes bone on bone. So in between the joints, we have a cushion, and that's called a bursa. And with time, that cushion starts to wear, going back to that wear and tear. And instead of that space having that nice bursa in there, it wears and tear and it becomes bone on bone. And that's when patients end up needing things like surgery, because at that point it's just painful and no intervention other than surgery can really help. That's when you need a total replacement. So let's say you present with these symptoms and you come to your doctor. Of course, when you go to your doctor, you will get a thorough physical exam. They'll be looking at all your joints and maybe having you walk, especially if you're having pain in like your back, your hips, your knees. You may get an x-ray. On x-rays, we can see something called osteophytes or bone spurring, they may call it. Like I said, sometimes you can have swelling and maybe even some tenderness. We don't necessarily need to get blood work, but if you do end up getting blood work, and again, this is all to your physician and your doctor's, their decision, that what they feel is best for your care. Sometimes we can see elevation in inflammatory markers that we get. So those are some things. Again, there is that poor man's test. You may come in and you may be textbook just how you're describing it. And your doctor may not get any tests at all, because again, it can be mostly a clinical diagnosis. And of course, when we treat it, which I will talk about, if it's not getting better, then they may do some more testing or imaging. So treatment, what do we do? So of course, lifestyle modification is number one. And lifestyle modification meaning diet and exercise. So of course, if we have somebody who is overweight or obese or morbidly obese, we do encourage them to exercise and move about. I know seems counterintuitive because you're probably like, my bones are hurting, my joints are hurting, how am I going to get out there? But in reality, it does really help. So losing that weight, because again, it takes that pressure and that pounding off of those bones. So again, those weight-bearing bones that we talked about, the knees and the hips and the low back. So it takes that off. Another treatment plan that we can do, again, usually we call it conservative treatment, is when we do more so lifestyle modification. If that doesn't help, then we can do anti-inflammatories or NSAIDs, so like Motrin, ibuprofen. Again, with itis, that is inflammation, so you can use these anti-inflammatories. Sometimes patients are given steroids. Sometimes they will even get a steroid injection into the joint, and a lot of times this can last for a few weeks up to a few months, and give them relief. Again, if that bursa is all the way gone and it's bone on bone, you may not get as much relief. And over the past few years, they have more advanced treatments where if you go to a specialist, they can inject, it's almost like a fake little cushion in there, and it's like a gelatinous material. So gelatinous material just means like Jello, so it's a little softer but sturdy, a little sturdier than Jello. And they inject that into the joint to give that cushion effect. So it's almost like a pseudo cushion or a fake cushion that stays in there, so it helps maintain that joint stability. Of course, if all of that does not work and it's bone on bone and the pain is just interfering with your quality of life and you can't get things done and you're in excruciating pain, of course, then you would see an orthopedist who is a bone surgeon, and it would probably be a replacement for that or whatever they feel is necessary for you. So with that being said, we're going to hop over to rheumatoid arthritis. Like I mentioned, this is autoimmune, so there is a genetic component to it. Again, what's different, we're going to juxtapose osteoarthritis and rheumatoid arthritis. With osteo, again, most of the pain was unilateral, so one-sided. So again, like the right hip, left knee. Whereas in rheumatoid arthritis, it's usually bilateral on presentation. So patients will come in saying that both of their hands are hurting, or both of their hands are weak, or both of their ankles are hurting. One thing with rheumatoid arthritis, we can see deformities of the hands. So the joints are very swollen. If you know of anybody or if you have rheumatoid arthritis, you would be aware of this. Patients can also get what we call ulnar deviation, where the hand itself and the joints start twisting. Same thing with what we call a swan neck deformity, where again, it's just that the hands and the joints just start to twist. And also in rheumatoid arthritis patients, we can see what's called rheumatoid nodules. And sometimes that's the first presentation. So it's a little bump and it's usually firm and it's under the skin. So it's not above the skin. So it's not like a boil or anything. So you'll just see a lesion. A lot of people who I've seen with rheumatoid nodules come in and they think it's a wart. But if you've ever had a wart, warts are rough on top, whereas the rheumatoid nodule is a smooth nodule under your skin, and pretty much you're kind of like, oh, what's that? And again, it's usually firm, doesn't move. Again, a difference between osteoarthritis and rheumatoid arthritis, like I mentioned, osteoarthritis will affect the distal interphalangeal joints, so the ones furthest from you, whereas rheumatoid arthritis will affect the proximal and then the metacarpal phalanges. So again, you'll see that swelling in these joints. So again, that's another differentiating factor between rheumatoid and osteoarthritis. And another big thing, again, going back to my sarcoidosis talk, if you missed that last week, check it out. But with autoimmune diseases, unfortunately, other organ systems are affected. So again, of course, with rheumatoid, everybody thinks of bones and joints. But because it's autoimmune, we have patients, as the disease progresses, it can also affect their eyes, their skin. They can have ulcerations, their heart, their lungs. So again, this disease can progress if it isn't treated appropriately. So how do we diagnose rheumatoid arthritis? So again, like I mentioned with osteo, a little bit more clinical diagnosis can be done there. However, with rheumatoid, we do have specific rheumatoid blood tests for diagnosis because again, it is autoimmune. So you can get something called a rheumatoid panel blood test, which includes a rheumatoid factor and what we call an anti-CCP. That's just a special peptide, so antibody peptide. You don't need to know all that, but if these are elevated, not necessarily both have to be elevated, just one, research has shown that sometimes a person may not necessarily have a rheumatoid factor, but the anti-CCP may be elevated and vice versa. And of course you can get x-rays, and the x-rays can show erosion of the bone. So again, with rheumatoid arthritis, there is a workup that goes with that versus osteoarthritis, which again can be a clinical diagnosis. So treatment. So the treatment of rheumatoid arthritis is also quite different from osteoarthritis. Of course, we always encourage lifestyle modification. One big thing, again, because I cannot reiterate enough, is that because rheumatoid is autoimmune, we just really need to get those patients treated as fast as possible to slow down any progression of the disease. So again, with the treatment of rheumatoid arthritis, it is very important for those patients where that disease has either been diagnosed or the suspicion is very high to be referred to a specialist called a rheumatologist. Rheumatologists specialize in autoimmune diseases. So again, like last week I talked about sarcoidosis. Normally those patients do see a rheumatologist. Now, as far as medications, normally these patients get started on a class of medications called DMARDs, and the most common one is methotrexate. These patients can also use anti-inflammatories, the same thing like NSAIDs, ibuprofen, Motrin, and steroids are also used, especially for acute exacerbations. So again, like with any autoimmune disease, a lot of times patients can do well and then have an exacerbation where they have worsening of their symptoms or progression. So again, ultimately the bottom line, especially rheumatoid arthritis, one of the keys is that you want that diagnosis to be confirmed as soon as possible and getting in with the rheumatologist to be treated as soon as possible so that the progression of the disease is slowed down. So I hope this helped you today, and I hope you learned more about osteoarthritis and rheumatoid arthritis, the differences between those two. Again, one of the major differences is that osteoarthritis is more wear and tear, and the majority of people will get osteoarthritis, whereas rheumatoid is an autoimmune disease and has a genetic component. Remember, it is Arthritis Awareness Month, so definitely read. The articles are always coming out. Just as an aside, there's other types of arthritis, just to name a few. We have gouty arthritis, so I'm sure people have heard of gout, where you get that one most common joint is the toe gets swollen and it's painful. So patients can get a gouty arthritis. There's also psoriatic arthritis, which is associated with psoriasis, which is another autoimmune disease. That we can see some patients with psoriasis have psoriatic arthritis. So they have psoriasis, but their bones also become involved in the disease process. So again, this is just to remind you how important arthritis is. I know when we don't suffer from a disease, we take it for granted, but it's always good to be knowledgeable and to know that things are out there. So in case yourself or anybody in your family are having any symptoms, you are aware and know that they need to get seen. So again, I hope you guys continue to be safe. So today we're going to end this clip with a Tripsy treat. That's right. So thank you again for watching, and don't forget to wash your hands, kiss your kids, love your family, and say your prayers. Good night. Bye-bye.